like a surgeon.
Ladies and gentlemen, welcome once again to another episode of the Think Clinical podcast. My name is Hamza. This is the final episode, the fifth and final episode of our series on the healthcare leadership podcast series. And this is going to be exciting because we are going to be looking at something very practical today. We are going to be looking at the African CEO's first 90 days, then 3 years, then 5 years. What should you be paying attention to? What is going to make the most sense? How should you structure your transition? Because we've talked about all these things. We've talked about how AI can impact you. We've talked about people coming from the diaspora. We've talked about just the obstacles that and the differences in leadership skills that you need to have as an African CEO. So what are we looking at right now? What is going to be your first, how would your first 90 days look like? How would your 3 years look like? How would your 5 years look like? This is very practical, and this is based on talking to so many CEOs that I've seen and I have admired, and I know they have the skill set to be able to lay the blueprint for you not to walk into the same situations that they might have walked into, and be able to appreciate the full value of that position. So this is going to be a good one, because there's a graveyard in African healthcare, and it's not a physical space. It is something that is real though, and it's full of strategy plans that were beautifully formatted and never implemented. So we have hospital transformation initiatives that launched with fanfare and died in the third month. CEOs who will arrive with vision changed everything in their first 60 days and then found themselves fighting fires they had inadvertently started, because they moved before they understood. They led before they listened. I've been thinking about this graveyard for a long time, and this is why I started talking to people. And because of the failure of the African healthcare leadership, it's almost never a failure intention. The people who take on these roles generally want to build something, and they want to do something very meaningful, but the failure is almost always a failure of timing, moving too fast on wrong things, moving too slow on the right things, and not having a framework for what the first phase of leadership should accomplish versus what the third phase of leadership should accomplish. So today, I want to give you that framework, a temporary blueprint for African healthcare CEOs from their first 90 days through the first 3 years, through the first 5 years, and what you should be doing, what you should be building, and critically what you should absolutely not be doing at each phase of this. My name is Dr. Hamza Asumah. Welcome to another episode. Happy to be here. Please remember to subscribe, like, and share, and we'll jump right into it. So the first 90 days, how does this look like? The single biggest mistake new African CEOs make in the first 90 days is mistaking activity for leadership. So they start with so much action, and they think that's how you should lead. You have been given a mandate, and the board has expectations. The staff is watching. There's organizational dysfunction that you can see from a parking lot, and there's an almost overwhelming impulse to start fixing things immediately. To demonstrate that you are decisive, capable, and worthy of the role, you jump right into it and you start getting everything going. You need to resist this with everything you have. Please resist it. The first 90 days are not about fixing. They're about understanding. And your primary task in the first 90 days is to build an accurate map for the organization. Its formal systems, its informal power structures, its cultural norms, its financial reality, and its narrative about itself. Every organization has an official story and a real story. Your job is to first 90 days is to find the real one. That's what you're supposed to do. So here is specifically what that means in practice. In your first 90 days, your calendar should be dominated by listening sessions, one-on-one conversations with every member of your senior leadership team, department head meetings, not to present your vision, but to ask questions. Walk around through every clinical and administrative area of the hospital. What do you see? What is the physical state of the environment? What does patient flow look like? Where are the obvious bottlenecks? You cannot lead what you have not seen, right? This is where you spend your time. You should also be spending your time in the first 90 days on the 3 specific areas of data: financial performance, not the PowerPoint presentations version, the actual account level data; staff turnover by department over the past 24 months; the patient satisfaction and complaint data, however it's collected. And these 3 data sets will tell you more about the organization's health than anything else: staff turnover, financial performance, and patient satisfaction or complaint data. Look at those. And in days 31 through 60, you are deepening your roadmap or your map. Now you are having more candid conversations with informal leaders, the long-tenured staff members, the physicians who have not been there for 15 years and have been there for 15 years and have seen 3 CEOs come and go. What have they tried before? What failed? What is the unspoken reason it failed? What are the cultural sacred cows? The thing is, what if you touch them will generate resistance that no organizational chart can protect you from? You are also in the phase identifying your quick wins. Not everything needs to wait. There are usually a small number of changes, 3 to 5, that are both clearly beneficial and low risk, that do not require deep organizational buy-in, and that can be executed quickly enough to demonstrate competence and build goodwill. Fix the obvious: the broken equipment in the waiting room that has been there for 2 years, the staff toilet that nobody has repaired, the scheduling system that creates an avoidable bottleneck every Monday morning. They are not strategic wins. These are credibility wins. And the credibility is a currency you spend on the harder changes later. In days 61 through 90, you are communicating your preliminary diagnosis. Not your strategic plan, your diagnosis. What you observed, what the data shows, what you think the organization's most important strengths are, what you believe the 2 or 3 most critical challenges are. You share this with your board. You share with your senior team. You listen to the responses carefully, because how people respond to your diagnosis tells you a great deal about the change readiness for the organization. And at the end of the 90 days, you should be able to answer 5 questions. What are these questions? 1. What is the organization's actual financial position? 2. What are the 3 to 5 informal leaders whose support I need to change anything meaningfully? 3. What is the one thing that, if fixed, you have the highest positive impact on patient outcomes? 4. What is the one thing, if not addressed, could destroy the organization in the next 12 months? And then, what is my own leadership brand in the organization? How am I perceived? And is that perception working for me or against me? These are the questions you should be able to answer. 2 years, years 1 through 3 now. If your first 90 days are about diagnosis, years 1 through 3 is about building the operational engine. And this is where strategy becomes structure and structure becomes habit. And the 3 most important things that you build in this phase, in this order, are financial sustainability, people infrastructure, and clinical quality systems. Let me explain. Financial sustainability first, and I cannot say enough. Every other ambition you have for the organization depends on its financial health. And a hospital that is hemorrhaging cash cannot invest in equipment, cannot retain staff, cannot build new programs, cannot attract the kind of talent and capital that will allow it to grow. Financial stabilization is not a finance department problem, it's a CEO problem. You own it. What does this mean practically? It means that you know your numbers intimately: revenue by payer category, collection rates by insurance company, expense variance by department, cash micro manager. But because the numbers tell you where the organization is telling the truth and where they're telling stories, it means you have made the hard decision about revenue. Which services are financially viable and which are not? Which payer relationships are worth sustaining and which need to be renegotiated or exited? What's the pricing strategy for self-pay patients? In a way that both ethical and financially sustainable. It means you have tackled accounts receivables. In most African private healthcare facilities, AR aging is a silent killer. We have 60, 90, 120-day-old claims sitting in insurance pipelines that nobody is actively pursuing. A systematic AR cleanup with dedicated follow-up protocols, aging reports reviewed weekly, escalation pathways for stuck claims can unlock significant cash without any new revenue at all. Okay. So a McKinsey analysis of private hospital group performance in emerging markets found that hospitals that implemented structured revenue cycle management protocols within the first 18 months of a new CEO's tenure improved their net collection rates by an average of 12 to 18 percent points, representing in a 10 million annual revenue hospital between 1.2 to 1.8 million in recovered revenue. The second thing, people infrastructure. By year 2, you need to have built or began building a management team that does not require you to be present for every decision. This is the CEO's deepest operational challenge in African healthcare settings. Building bench strength in an environment where experienced healthcare managers are scarce and turnover is high. What does this look like? It means intentional investment in your direct reports, monthly one-on-ones or that are substantive, not performative. Clear performance expectations that are documented and reviewed. Deliberate exposure of your promising managers to board meetings, external conferences, and strategic conversations that expand their capability. It means you are thinking about who could succeed you in every role on your senior team. Not because you are leaving, but because organizations with succession death are organizations that are resilient, and organizations without it are departure away from crisis. The third one is clinical quality systems, and this one often gets prioritized in the face of financial pressure, and that's a dangerous mistake. Clinical quality is not separate from financial performance. Poor clinical outcomes drive malpractice liability, patient complaints, insurance disputes, and reputation damage that in an era of social media can cascade into patient volume loss very quickly. Building structured clinical quality systems, morbidity mortality reviews, patient safety incident reporting, clinical protocol standardization is both a clinical, ethical imperative and a financial protection strategy. By the end of year 3, the organization should have a financial position that is stable and improving, a management team that is functioning with genuine delegation, a clinical quality infrastructure that is systematic rather than an ad hoc, and a culture that is beginning to take on the characteristics you want it to be: accountability, candor, patient-centeredness, and adaptability. So 3 years, so years 4 and 5. If years 1 through 3 are now about building the engine, years 4 and 5 are about deciding what kind of vehicle that engine is going to be powering. By year 4, if you have done the work, you're operating from a fundamentally different position. The immediate crises have been managed. The financial foundation is solid. The team is functioning. The culture has shifted. And you have a choice that not every CEO gets to face, because many do not make it to year 4, just so you know. And you have the choice of what to build next. This is where the African healthcare CEO's vision work really begins. Not a vision statement that goes on the website, the actual strategic architecture of what the organization becomes over the next decade. So for most African private healthcare organizations, there are 3 expansion directions worth serious consideration. The first one, geographic expansion. If you have built a functional, financially sustainable facility, you have to build a replicable operational model. Can you open a second location, a third? Can you acquire struggling facilities and apply your operational playbook to turn it around? This is where the healthcare support organization model we discussed in episode 3 becomes relevant. The second service line expansion. The second is service line expansion, and what clinical programs does your catchment population need that you are not yet providing? This requires genuine epidemiological analysis. What are the leading causes of death, disability in your region? Where are the patients currently traveling 2 hours to access care because it does not exist locally. Service line expansion does well in done well in is not a prestige. It's about market need and clinical impact. And the third is academic and training integration. The African healthcare organizations that have achieved the greatest long-term stability are often those that have built training programs, nursing schools, residency, or continuing education, and that create a pipeline locally trained staff. Training integration is a long-term play, and this is something you need to pay attention to. In closing, the African healthcare CEO faces a timeline problem. The challenges are urgent, the resources are constrained, the expectations from boards, from communities, from donors, from your own ambition are enormous. And the temptation is to try to collapse the timeline, to do year 3 work in year 1, to chase the year 5 legacy before the year 1 diagnosis is complete. Resist the temptation, not because agency is wrong, but because premature agency applied to the wrong things at the wrong time is how organizations are broken by the people who were trying to fix them. Listen first, map the real story, stabilize the foundation, build the engine, then build the legacy in that order, with a discipline over a timeline. Africa's healthcare systems need leaders who can go to the distance, not just leaders who start fast. The continent does not need more spectacular launches. It needs more quiet, disciplined, decade-long builders. This has been another episode of Think Clinical Podcast. Thank you so much. And this has been the last episode of African Health Leadership Series on the Think Clinical Podcast. We appreciate you for sticking with us over the last 5 weeks, and we will see you in our next episodes. Do have a nice day.
Cold room, warm heart, I keep my head steady. Bills don't run my life, now I make the plan ready. Late nights, clean charts, big dreams in the margins. I came for the scalpel, but I built my